Hi, my name is Monazza Azam. I'm a PGY2 at Wellstar Atlanta Medical Center. I'm here to talk about my case lack of plasmapheresis in a critical case of thrombotic thrombocytopenic purpura secondary to COVID-19 infection. Now, to start off, thrombotic thrombocytopenic purpura, also abbreviated TTP, is a fatal anemia caused by reduced activity of the enzyme ADAMTS13. Now, without this protease, multiple small thrombi can arise throughout the body, most commonly resulting in blood clots, neurological damage, and even hemolytic anemia. Now, given its high mortality rate, it is very important for us to rapidly identify and manage this disorder. I will be talking about an interesting case of elderly female. She has prior history of acquired TTP secondary to Plavix and presented to us with a relapse, likely due to reactivation by COVID-19 and or influenza infection. She unfortunately was unable to receive plasma exchange for a treatment. However, she responded very appropriately to a second-line approach, including high-dose steroids and rituximab. Our 60-year-old female presented to us with past medical history of hypertension, hyperlipidemia, osteoarthritis, history of embolic stroke with a loop recorder, history of acquired TTP secondary to Plavix, peripheral vascular disease. Her main complaint when she came here was myalgia and shortness of breath for a few days duration. Upon physical examination, we noticed her to be lethargic with some mild confusion and conjunctival pallor. Upon review of labs, the first thing we noticed were her platelets were significantly low at 13,000, and as we completed our full workup, we found her to be hypoxemic on ABG. Her plasmic score was a 7. Her ADAMTS13 enzyme activity was reduced at less than 3%. We did send out a peripheral blood smear that showed few schizocytes, and her hematology labs were compatible with hemolysis. As we can see in figure 2, summarizing her labs when she came in, her hemoglobin was at a 13.9 and slowly decreased to a minimum of 10.6 on day 10. Her platelets were reduced at a 13, and as she was started on high-dose steroids and rituximab, did improve and was within normal range prior to discharge. She did have a slight elevation in creatinine, total bilirubin, LDH, when she came in, which did improve prior to discharge. Her ferritin was significantly elevated at greater than 1500, and her ADAMTS13 enzyme activity was decreased by less than 3% when she came in and gradually went up to 14% on day 10. She was found to test positive for both COVID and influenza B. Hematology oncology was consulted and initially recommended her to be transferred out to receive plasmapheresis. However, multiple hospitals were on diversion due to COVID-19, and given her status for COVID and influenza isolation, she was placed on a waiting list. Therefore, we did start her immediately on high-dose steroids, followed by rituximab for TTP management. On day 14, her platelets did return to normal range, and once her oxygenation requirements improved to room air, she was safely discharged with instructions to follow up with hematology oncology and her primary care physician. Now, given that TTP is a rare but extremely deadly disease, it does occur in 3 to every 1 million adults annually. It is important to note that although our patient had a previous episodes of acquired TTP secondary to Plavix, her also being African American and female increased her risk at baseline. We did conclude that this repeat episode was likely due to relapse secondary to COVID and or influenza virus that resulted in inflammation and immune system dysregulation. So although our patient presented to us critically ill, and gold standard is plasma exchange therapy, we had to look elsewhere to appropriately manage her, and luckily she did respond very appropriately to high-dose steroids and rituximab. In conclusion, it is really important for us to be aware of the resources we have in our facility and how we can appropriately manage patients safely. Thank you.